I would like to ask Ragnhild to come to the floor. And Ragnhild is working for the Norwegian Institute of Public Health as a nurse by training and senior advisor at the Norwegian Institute of Public Health, and one of the strongholders of the Med Task Force and a dear friend. So, Ragnhild, is your presentation? Look for it. Yes.
Thank you so much for the invitation. I'm also very happy to be here in Brussels, and I'm very happy to speak to all of you, and especially the cultural mediators, which Hans often talks a lot about when he is out traveling in other countries in Europe. And we don't have such a nice service in the Norwegian healthcare system, but we have other things, and I will try to give you an overview and some examples of good practice from Norway. So first I will just give some brief facts of Norway, because we are a little country and maybe you don't know a lot about Norway. And then talk about who are the migrants in Norway and how we work with equitable healthcare. And since I don't work in a hospital, I work in the Norwegian Institute for Public Health, it will be more on a national level. Yes. So this is Norway. We are a democracy, and with a king, constitutional democracy, and we have a little bit more inhabitants than Ireland and Reggio Emilia. We are soon 5.3 million. And Oslo, where I live, that's the capital, and 70% of the population in Norway is migrant and children born to migrant parents. So 14.4% are migrants. But in Oslo, where I live, the migrant population is around 33%. We also have an indigenous population, that's the Sami people. They were not colonized in the same way as the indigenous people in Norway, and now in Canada, because in Norway, the Sami people, they lived there longer than we Norwegians, but we also lived 10,000 years maybe or so in Norway. So it's a bit different story, but many similarities. So the Sami I'm not working with the Sami people, but there are people working in indigenous health, like in Canada. I have contact with them because there are many similarities. And there are around 40,000 Sami people in Norway. And mostly they live in the north, but also a great group live in Oslo too. And we just have sat down a Truth and Reconciliation Commission in Norway too. They started their work this year, and they will work for the next 3 years, I think. Our healthcare system, it's a national healthcare system, publicly financed and universal coverage to almost everyone. But asylum seekers have some restrictions on their access to healthcare, and of course, unfortunately, undocumented migrants also face a lot of restrictions when it comes to healthcare. There is an overall goal of the Norwegian healthcare policy, and that is to ensure equal access for all. So that's equity in health. And I guess David would show in the MIPEX results that this is quite embedded in Norwegian policy and legislation. Another thing is what happens in practice. In Norway now, as I said, 14.4 migrants living in Norway, and 3-point-something children of migrants, so almost making up to 1 million migrant or Norwegian born to immigrant parents. And here are the 10 bigger nations with the background of the migrants. So you can see the Poles are by far the largest group, and then Lithuania, Somalia, Sweden, Pakistan, Syria, Iraq, Eritrea, Germany, and the Philippines. So also a very diverse group, and like, I guess, was it, yeah, it was you in Quebec, or I don't remember, but from more than 200 different countries, and speaking also a lot of different languages. So when it comes to equitable healthcare services in Norway, as I said, we have a very strong legislation. It's very clear formulated in the Patient Rights Act, the Health Personnel Act, the Specialist Health Services Act, Primary Health Care Services Act, and so on, that all services should be equitable and accessible to all, regardless of background and origin. Also, there are done quite a lot of research in Norway in this field and development projects, but the important, of course, is what's happening in the practice, in the encounters between health personnel and the patients. Okay, but just to say something on the policy level, I now work in the Unit for Migration and Health in the Norwegian Public Health Institute. But in 2003, the government set up a Norwegian Center for Migration and Minority Health. We became part of the Institute of Public Health last year. So that was one important step to start to work with migration and health in Norway. That was in 2003. Here you see my colleagues and myself when we went to a seminar in beautiful Lofoten Island, far up in the north. And then in 2013, the former government launched a national strategy on migrants' health, which was also a very important tool for us in the field to have this document. And as you can see from the aim, the three overall aim in this strategy, there were high, not expectations, but what you call it? Objectives, thank you. Of this strategy. They were maybe not fulfilled. I don't think we can say that healthcare providers at all levels have basic knowledge about all the migrant groups' disease incidents and the cultural challenges. But anyway, it was a very important document for us, and we used it a lot when arguing for the need for focusing on migration and health. This was just launched by the former government just before the election, and we got a new government. And they, fortunately, they said they supported the strategy. They didn't really, use it a lot, but they didn't put it, they didn't disregard it either. And we worked, because this was from 2013 to 2017, so we worked hard on trying to advocate for a new strategy, or better, a more concrete action plan. But now in Norway, it's the second period of a conservative right-wing government, so we didn't get a new strategy. So instead of focusing on the top level, I think it's important to focus on bottom up, because there are more and more health personnel having an interest in this field and working and want to do projects and so on. So then we decided to kind of cultivate all the good work that goes on the ground floor. in May, we got a strategy for health literacy, the first one in Norway. And since we didn't get a new migrant health strategy, we think this will be an important policy document to use for us. I just Google translated the main points there that I think it's important for our field. So we will use that. So what do we do at my unit and also in the Norwegian Institute of Public Health? Of course, there is a lot of research and development, both within my unit, but also in the institute overall. A lot of use of registered data to look at inequities in health and so on. I don't have time, or I'm not prepared either to go into all the details about that. I want to talk about the networks we have. We also do, of course, a lot of teaching and dissemination. When we had the strategy, one of the tasks that was actually described in the strategy, and there came some money with it, was that we should, NACMI, my former institution, should develop a training course. So we developed a 2-day introductory course in migration and health that we run 3 times a year. So during the course of the years, we reach out to quite many health personnel with our course. Sometimes, or we run it in-house like 3 times a year, but we also often cooperate with hospitals and go and have special courses in the hospitals for the employees. And also we use Facebook. We have a Facebook. We had, with the NACMI, the former institution, our own Facebook page, and we were able to keep that when we became part of the Public Health Institute, and that's also a way of communicating and disseminating knowledge on migration and health. And this is our former director, Bernadette Kumar. Now she's on a leave because she lives in Nepal for the moment, but she is very active on the field, and here she's talking in the UN during a high-level meeting earlier this fall. So she's a very important person in the field of migration and health. And then we have 3 different, or actually, no, we have 4 networks. And I coordinate 3 of them, and I will also start to coordinate the research network from next year on. So we have a hospital network, which was actually started already in 2006 after the European project on migrant-friendly hospitals. And 15 hospitals are in that network, and the people representing the hospitals are people working with equity and migration and health in the hospitals. And of course it varies from different hospitals, how much focus and how much resources the person have doing this work. Like Oslo University Hospital, they have 2.5 position designated working with equity and health. But maybe a smaller hospital, the person has this responsibility together with many other tasks. So, and then in 2012 we started a network of NGOs. So it's called Network for Voluntary Organizations in Migrant Health, and it's many of the big Norwegian patient organizations like the Diabetes Association, the Cancer Organization, Mental Health Organization, Red Cross, Caritas, and so on, and also smaller immigrant-led organizations, but working with a focus on health issues. And then with the increase of refugees coming in 2015, we started up network for the municipalities. Even though we are a small country, there are 400 or something municipalities in Norway, so we couldn't invite all into the network, so we did a selection of the biggest cities and the municipalities around Oslo who have a high percentage of migrants living in their municipality. And then in 2018, last year, our colleague Esperanza Diaz, she started a network for researchers to kind of get an overview of all the research, different research that is being done in migration and health in Norway, and try to avoid that people duplicate almost the same projects and so on. So we just finally got some information about the networks on the webpage of the Public Health Institute, and apparently people are, subscribing to the webpage. So I just in one day got 10 emails of people, can we be part of your network? So that was very nice. So more municipalities and organizations have become part of the networks. This is a picture some years ago from the Migrant Friendly Hospital Network. And as you see, there are the logos of all the different hospitals in the network. Most women working in this field. And when we had our 10-year celebration in 2016, we did an evaluation and asked the hospital both about their plans for future work, and as you can see here, many things that resonate with what you already have said in the other presentations, that you need a whole organizational approach, we need action plans, you need to prioritize different areas, to use more technology in patient communications, better mapping of the challenges, and strengthen cooperation with user and immigrant organizations, develop local networks, and so on. And also increase focus and quality in interpreter services. And then we also asked about the experience of being part of a network, and that was very positive, and it's always so positive when we have the meetings. In each network we meet twice a year for a whole day each time, and the meetings are kind of divided into two parts. So we will provide some competence, something to increase the competence in the network, some presentations from either some researchers, colleagues of mine, or someone else that's had some new research or project to present. But the most important is to have, after lunch, we call it the round, where each hospital gives an update on what they are working with, what are the challenges, and so on. So it's always so nice to have this meeting. I'm always very happy afterwards and more motivated. And even though we have this Norwegian saying, it's things takes time. Ting tar tid in Norwegian. And some of you already mentioned it, you have to be patient. It takes time. But when we look back, a lot of things have improved and a lot of good things are happening. So now I will just briefly give some examples from some of the networks. This is a project, it's called City District Mothers. It's actually a concept adopted from Denmark. And it's immigrant women that gets quite an extensive training. I think it's 17 different modules on health, on social services, on being a parent, cooperation with the school, and so on. And they become resource persons for other women in their local area. And also for the health services in this area can use these women to reach out, to plan different activities, seminars, and so on. It's quite new. They've been operating for 1.5 years maybe, but it's already put up in, I think it's 5 or 6 city districts in Norway, in Oslo. More than 100 women have been trained to become city mothers. And they're also trying to start city fathers. So that's very interesting because it's important to engage with the men also in the community. And now, together with this Norwegian organization called Women Health Organization, they're going to pilot like village mothers too in the more rural areas of Norway. So this is, I think, a very nice project. And they are part of the NGO network that we run. This is an example with the Cancer Association, together with some of the minority organizations. They had this campaign, or it's a national campaign, Check Yourself, on cervical cancer screening. But they had this cooperation with minority organizations to engage with minority women, because I guess it's the same in other countries that the screening rates are much lower among minority groups. So that's a nice project. Here the information in different languages, as you can see. This is from my local city district. It's the public health services. The white woman there, she's a physiotherapist working with health promoting activities in my city district, and she has engaged the woman lifting her. She's one of these key persons in my area. Her name is Ramayama. She's of Somali background, and she has a broad network. So they plan together to get more immigrant women coming to the training activities offered by the city district. This is a hospital trust just outside Oslo. They made this action plan on equitable healthcare to the immigrant population from 2019 to 2021. They are in the hospital network, and they have 4 priority areas in this action plan. It's knowledge on health and health challenges among the population in the catchment area. Then it's communication and interpreter services. Then it's cultural competence and user involvement. And then it's accessibility and adaptation. This is from the hospital in Bergen. They employed, they call it a hospital imam, the first and only one in Norway so far. He was employed in a 20% position from last year. And so far the experiences are very good. In the same hospital in Bergen, they have a pilot project. They call it the Language Bank, and that's to the employees that have a multilingual, multicultural background can voluntarily, if they want, be registered in this language bank and be kind of language assistants at times when you don't have the possibility to have an interpreter. And it says that the language assistant is not a professional interpreter, but can have that role in emergency situations. And this happens already in many hospitals, that employees with multilingual background are used as interpreters, but this project is kind of trying to do it in a more systematic way. So that's interesting. Also, the Oslo University Hospital has a strategy for equitable healthcare services and diversity. It's the second strategy they have. There is also a project going on at Oslo University Hospital with multicultural doula, which is immigrant women that have lived quite some time in Norway and themselves have given birth at a Norwegian hospital or in the Norwegian healthcare service. And they also get a quite extensive training to become a doula and then to be a support for women that have newly arrived or have little network around them, little family, before and during birth and some period after. This has now been for 1.5 years, I think, at Oslo University Hospital, and they just got some, and that's a project, it's a cooperation with the municipality of Oslo and this women's health organization, NGO, which is in the NGO network. And now this project got funding from the Directorate of Health, and they will also expand it to 3 more hospitals in Norway. So that's very interesting. And then at the Oslo University Hospital, they have had an interpreter service the last 5 years after they did an evaluation and looked at the qualifications of the interpreters that were used in the hospital, and it was very poor quality. So they decided to build up their own service. And this service is also can be used by 2 other hospitals in the Oslo area. And now they have a project with a psychologist to support the interpreters, because it's a very, I'm sure there are, I guess it's also the same for the cultural mediators, that you experience many situations that can be quite challenges, and it's important to take care of the mental health and of the interpreters and the cultural mediators as well. So that's an interesting project. So the road ahead, another picture from my beautiful country. We are, for the first time, actually in 2 weeks, on the 27th of November, we will have a one-day meeting where we bring all the networks together. We have had plans for that for some years, but now it's finally going to happen. And then, of course, we will have some short presentations in the beginning of the day, but the most important thing is that people get to know each other, talk together, and do some good work together. So we put up 10 different teams for workshops. I'm not sure I'm going to remember all the 10, but these are teams that we have been discussing in the meetings and have had presentations on in the different networks meetings. It's discrimination and health, it's immigrant men and health, it's women's health, it's adolescents and young people and mental health, it is cultural mediation, it is health promoting activities, and some more teams. And we want every participant, they have to sign up for a team, and then they're going to work in groups, and they have to decide during the workshop on some activity that they are going to do together, the persons in the group, for the next year. So it's going to be some concrete results Maybe it's to plan a seminar together, a hospital, a municipality and some organizations. Maybe it's develop some teaching, small teaching. We don't have funding for this, so it cannot be too ambitious, but we want them to commit to work together on some specific thing that results in something concrete. So I'm very excited about this, and yeah, we'll see. But this is our motto, and I don't know about time, but I'm finished anyway. Thank you.
Thank you very much, Ragnhild. We have many ideas that could be put into practice if we had lots of money and even more important, I think, a lot of motivation. It's very important as well.